Hi and welcome to a new lecture on renal diseases. We are covering high yield MCQs and another part with detailed mechanisms, and the pathophysiology or physiology will be on the second set of the videos. So today we are here with renal diseases part 4. So our first MCQ is: a 25-year-old woman with no family history of kidney disease is diagnosed with severe and resistant hypertension. So a patient is here whose age is just 25 years young and with no family history of kidney disease. She is diagnosed with severe and resistant hypertension. What is your next step in the workup of her condition? Urinary met nephrines, renal Doppler ultrasound, CT of abdomen, or serum cortisol. So, what is the situation over here? Actually, this woman is so young and she has high blood pressure, and the most likely cause of this resistant hypertension is the renal artery stenosis in such a young patient. So, renovascular hypertension is actually the blood pressure elevation due to partial or complete occlusion of one or more renal arteries or their branches. It is usually asymptomatic unless it is long standing, but how it is diagnosed, that you can hear a renal bruit over one or both renal arteries, but it is less than in 50% of patients. So diagnosis is actually by physical examination and renal imaging with duplex ultrasonography. So answer will be renal Doppler ultrasound, or there can be magnetic resonance angiography, but angiography is done before definitive treatment with surgery or angioplasty. So renal Doppler ultrasound can diagnose this condition, but the if the question says that what is the gold standard, so the gold standard is renal arteriography is the gold standard for the diagnosis of renal artery stenosis. And okay, the next question again: a young patient, white patient, on her annual physical exam asks you to help her quit smoking. She is found to have right flank continuous bruit. Right flank continuous bruit. So we know that the kidney pain is mostly in the flank region, and there we can hear the continuous bruit. So the bruit that is continuous throughout systole and diastole is mostly the bruit of the renal artery stenosis here in the flank region. She is also known for her refractory hypertension, and the severe refractory hypertension or hypertensive crisis with mostly negative family history. It is also features of renal artery stenosis, and you suspect a secondary cause for her hypertension. So, which of the following is most likely? Hyperaldosteronism, Cushing syndrome, renal artery stenosis, aortic coarctation, and or pheochromocytoma. So, this is the renal artery stenosis. What happened? It is the most common form of curable high blood pressure and is estimated to affect 1% of all the hypertensive individuals. So causes of this are actually atherosclerotic plaques in 90% of the patients with proximal one third of the renal artery. It has atherosclerotic plaques. Usually it happens in the males with greater than 55-year smokers, that is smokers. Or if there is fibromuscular dysplasia that occurs in 10% of patients, so it will be in distal two-thirds of the renal artery or its segmental branches, and it usually occurs in young females which are less than 30 years of age. So here the patient is young, white, and she is female. So what happens, there will be decreased renal perfusion due to raised pressure, despite of raised blood pressure, but there will be decreased renal perfusion. So due to decreased renal perfusion, what happened, there will be increased renin, and then it causes increase in angiotensin, and angiotensin causes generalized arterial constriction, or and also release of aldosterone, which causes sodium and water retention. And the features, we see that there will be asymmetric renal size, increased creatinine. Even with the hypertension will not be cured by ACE inhibitor or ARB blockers, due to if we use these ACE inhibitor or ARB blockers, we have increasing creatinine, because if there is unilateral renal artery stenosis, we can still use ACE inhibitors, but if it has bilateral renal artery stenosis, we cannot use ACE inhibitor or ARB blocker, because they can exacerbate the renal failure. So in these patients, sometimes there is pulmonary edema with normal left ventricular function. So the features with right flank continuous bruit and refractory hypertension marks towards renal artery stenosis. Now, next question. 75-year-old patient with underlying chronic renal failure requires cardiac catheterization. Which of the following interventions is most likely to help prevent acute renal failure due to contrast induced nephropathy? So the patient has chronic renal failure, and now he requires cardiac catheterization. So the question is asking that which type of intervention we have to use to prevent acute renal failure due to contrast induced nephropathy, because the contrast will be used in his cardiac catheterization. So hydration with normal saline and mannitol, hydration with sodium bicarb, hydration plus a loop diuretic, or administrating phenoldopam or infusion of natriuretic peptides prior to procedure. So the correct answer is hydration with sodium bicarb. The most ideal thing here it will be just the usage of normal saline alone. If in the question there is normal saline alone, that we have to select that. But here in this question, normal saline is there but with mannitol. So studies of interventions to prevent acute renal failure in patients at high risk have shown that mannitol plus hydration does not reduce acute renal failure compared to hydration alone. So also there is no use of this natriuretic peptides in preventing acute renal failure. Also administrating this phenoldopam doesn't help any much, and hydration plus a loop diuretic. Adding loop diuretic to fluids was even not effective and may actually increase the possibility of acute renal failure compared to fluids alone. So hydration with bicarb or the use of N-acetylcysteine have some benefit, but the most accurate answer will be normal saline alone. But here in this question, normal saline alone is not given, so most suitable answer is hydration with sodium bicarb. A 78-year-old white male is scheduled to undergo CT with contrast. His current diagnoses include type 2 diabetes mellitus, heart failure, anemia of chronic disease, and renal insufficiency. So the patient is scheduled to undergo CT, and he also has renal insufficiency, type 2 diabetes, heart failure, anemia of chronic disease. Evidence supports the use of which one of the following to reduce the risk of contrast-induced nephropathy in this patient? IV furosemide, ascorbic acid, calcium antagonists, isotonic bicarb infusion, high osmolar contrast media. So again, We know, we have discussed, if there is option of normal saline, then that will be perfect, but if not, then bicarb or an acetylcysteine will be the next answers. A 72-year-old white male has new onset hypertension with a current blood pressure of 190 by 110 mm Hg. So 72-year-old male, he has new onset hypertension and now the current blood pressure is so high. Which one of the following agents can be used as part of a test for diagnosing renovascular hypertension but would also increase the risk of azotemia if used for treatment? So they are asking that which type of medication are used as a part of a test for diagnosing the renovascular hypertension, but it would also increase the risk of azotemia. So the ACE inhibitors or ARB blockers, because they dilate the efferent arteriole, so they usually prevent the renovascular hypertension because they cause dilation of the afferent arteriole. So, but at the other end, if the kidney is already in the compromised or in a failure state, so these drugs also increase the risk for azotemia if used for treatment. How? Because hyperkalemia is an associated problem and captopril renography is a useful diagnostic screening test. But the other agents are also useful for lowering blood pressure but may cause mild creatinine elevations. But however, cause the significant elevations of creatinine is seen with ACE inhibitors in the diseases of significant renovascular disease. Then a 57-year-old male with severe renal disease present with acute coronary syndrome. Which of the following would most likely require a significant dosage adjustment from the standard protocol? So we have already discussed that in a severe renal disease, ACE inhibitors or ARB blockers need a standard dosage adjustment most likely. So enoxaparin is ARB blocker, so we will adjust the dose of the enoxaparin because enoxaparin is eliminated mostly by the kidneys. So when it is used in patients with severe renal impairment, the dosage must be significantly reduced. For some indication, the dose normally given every 12 hours, then it will be given only every 24 hours. So enoxaparin, ARB blockers or ACE inhibitors, they should be very carefully used if the patient has already severe renal disease. And in bilateral renal artery stenosis, we don't use ACE inhibitors or ARB blockers. Okay, thank you for watching and don't forget to like and subscribe our channel to get all the videos. So we'll meet you soon with another set of videos.